Hi, I'm Wendy. Well, thanks, Mark, for, well, I feel really good now. So yeah, I've been working with patients strictly with this disease process of MASLD for the last 10 years, 8 with Mark. Thanks, Mike, for having me come speak today. And today is Global Fatty Liver Day. Millions of people suffer from this disease, and so awareness is key, right? So if you know somebody that has any of these metabolic risk factors, have you had it checked? You got to be advocates, okay? So I'm going to just talk quickly about who's at risk, and I know Mark really talked about that, but who's at risk for steatotic liver disease? How do we go about in our clinic to determine someone's severity of their disease? And then I'm going to talk about long-term management of MASLD patients. Next slide. So steatotic liver disease, as you know, the fatty liver disease, it's changed. The name has changed, and I will use NAFLD. I will back and forth. It is quite a thing to get used to it after 10 years of calling it one name, but I think the change was very needed. It was to help also to reduce stigma, and let's face it, liver disease has a lot of stigma. If you polled 100 people on the street and they asked what they thought about liver disease, they would say it was from drinking. So it's still a big perception out there. So steatotic liver disease is the overarching term, and then we have then MASLD, which is metabolic dysfunction-associated steatotic liver disease, or MASH, metabolic dysfunction-associated steatohepatitis. Next slide, please. And so MASLD then would be patients that have deposits of fat in their liver, but no inflammation. MASH, that fat that's deposited in the liver has started to cause an inflammation process to occur. And so steato means fat, and hepatitis means inflammation of the liver. So more and more inflammation from the fat over time leads to fibrosis. Fibrosis is another term for scarring. And over time, again, you'll end up with liver cirrhosis. This is not something that happens over a short period of time. Typically, it can be a 10 to 20 year progression. Next slide, please. So some steatotic liver disease facts. So it is the most common disorder of the liver in Western industrialized countries. It's the #1 reason now why people need liver transplants. It's become more common in the US and Canada as weight gain, obesity, and diabetes have become more common. The leading cause of death in someone who has this disease process is actually not liver related, it's heart related. Someone who has this disease is 3 to 5 times more likely to suffer a heart attack or a stroke than someone who does not have fatty liver disease. And then it's followed by cancer and then liver related death. Next. There's no signs and symptoms. This is a very silent disease. Our liver is the only organ that regenerates, and so it's very good at keeping it doing its jobs. And so only when it's in a very advanced state, so cirrhosis, is someone starting to feel the signs and symptoms. And it's still found incidentally. Most people still aren't going, oh, I want to be tested for fatty liver disease or steatotic liver disease. They're going for their annual physical and they're getting blood work drawn, oh, there's something funky going on with your liver tests. Or they might have had a vague abdomen pain, and let's send you for an ultrasound, and we don't know why you're having pain, but by the way, there's fat in your liver. So those are still the very typical ways this disease is being found. So Dr. Swain already talked about the metabolic syndrome. So the apple body style versus the pear, these are the patients that are more at risk to have fat depositing and more at risk then to potentially have more scarring in their liver. So visceral adiposity. So we know that 75% of people with obesity will develop fatty liver disease, and then of them another 23% or so will progress on to have MASH and then fibrosis. We know insulin resistance, diabetes, and pre-diabetic patients, are very high risk to have fat in their liver, and there is a bidirectional relationship between MASLD and diabetes, like Mark talked about. If someone has MASLD, you're at high risk to get diabetes. Somebody who's diabetic, it's very slim chance that you don't have fatty liver disease. So treating your hypertension, you're managing your triglycerides. Triglycerides is a sticky fat that sticks in our blood vessels. It sticks in our liver. And so that's why the heart disease component, because it's sticking in our blood vessels to cause heart disease as well. So, yeah. Okay, next slide. So how do we go about diagnosing steatotic liver disease? So first of all, we have to look at blood work. We do a form of non-invasive testing. We have to have an ultrasound of the abdomen to actually assess for fat. We do a form of liver stiffness testing that tells us about the health of a liver. In the community, it's called a SWI, so shear wave elastography. And then in a hospital setting, it's a FibroScan machine like you'll see at the back of the room today. And then plus or minus a liver biopsy. Not everybody who comes to see a hepatologist is going to get a liver biopsy, just so you know. Okay. So blood work. First of all, we talked about MASLD being a diagnosis of exclusion. We have to rule out anything else that can be going on in the liver to make the diagnosis. And a diagnosis of MASLD is if you have one metabolic risk factor and fat on an ultrasound. That is what a diagnosis of MASLD. And so obviously, once we make a diagnosis, whether you have simple fat in your liver with no damage, whether you have MASH where we know there's some inflammation and scarring, or whether it's cirrhosis, we do use lab to monitor patients' conditions long term. It tells us about liver health. So typical lab tests that I follow all the time, very frequently on patients, are, of course, someone's risk factors. Let's look at how their A1C, how is their diabetes in control? What is their cholesterol levels? Do they need to be on a medication? And typically, we know that statins are very safe for people to take that have liver disease. In regards to liver enzymes, so we have the ALT and the AST. So these enzymes will elevate when there's damage to the liver cells caused from inflammation. And then the alkaline phosphatase and the GGT, they can also elevate when there's liver cell injury. We look at ratios. If typically an ALT is higher or equal to an AST, when we start to see some switching and the AST now comes higher, it can also indicate some severe liver damage, possibly cirrhosis. And liver function tests, which are they're different than liver enzymes. They tell me how the liver is doing its jobs. And so we look at a platelet count, we look at the INR for clotting factor, we look at total indirect bilirubin and albumin. And then the other cholestatic liver tests, they're alkaline phosphatase and GGT, and that become elevated if there's an impairment of bile flow. Next slide. So the ultrasound of the abdomen we use it all the time, and it tells us many things. It's just not telling us about fat. We look at the size of the liver. The liver can enlarge if there's deposits of fat in it, because there's more volume inside the liver, so our liver can actually enlarge a little bit. We look at blood vessels that go in, and we measure size of the blood vessels that go in and out of the liver. We look at the appearance. Does the liver look nice and smooth, a smooth contour? Does it look lumpy bumpy? So all these things tell us about health of the liver as well. So fat shows up very bright and white. They call it echogenic. So on this slide you can see these, you can see they're very equal color. You can see these are the blood vessels that are, of course I can't see, but there's the darker area, those are blood vessels going through the liver. And on this, where there's fat in the liver, you can see the difference in the appearance. This is much brighter and whiter. And you can see, you can no longer see those blood vessels. They're obscured by the fat. So that would be a liver that has fat in it. Next slide. And then just to show you that lumpy bumpy. So a cirrhotic liver has lots of nodules from scar tissue, so it can have a very lumpy bumpy appearance. Next slide. Liver stiffness. There's community-based liver stiffness testing, so that's the SWI. This started in Calgary with Dr. Swain, and it's a way for the family doctors to send their patients through a community-based ultrasound, and they have a form of liver stiffness testing called a SWI. So what happens then, this is the ultrasound probe. They send an acoustic radiation wave through the liver, and that excites and moves the tissue. And then, make a long story short, the machine then measures the speed at which those waves go through the liver. So the faster the speed, the higher the stiffness is in the liver. So then there's more presumed scarring in the liver. Okay, the next slide. And this is the FibroScan that we have in hospitals. That's the name of what we use. Again, it's a little different, but it's a tiny little probe. And again, we send the wave through the liver. It measures the speed. And so it always takes 10 measurements to get the average, and that's called your FibroScan or your liver stiffness score. Okay, next slide. So a liver biopsy, it's still considered the gold standard for finding out what's exactly going on in the liver. No one test that we do tells us everything that can go on. We have to look at a lot of things to get the exact information, and even then sometimes it can be challenging. But it's most important to do a liver biopsy when the liver is found to be stiffer, when we suspect more scarring. And but it is an invasive test, of course, and so it's taking a little tiny sample out of the liver and looking under the microscope. And then, of course, the pathologist then labels it F0 to F4 fibrosis. You've probably heard those terms before. So this is a population of patients that are getting the liver biopsy then. The people that the liver stiffness is telling us they have some inflammation or potential scarring, their lab work, the ultrasound. So this is the patient and here that are getting the liver biopsies, because we can't tell how much scarring they have. You could have a little scar, a bit of scarring, or almost cirrhotic, pre-cirrhosis scarring. So that's why we really use the liver biopsy. And so I always like this slide. Those are our liver is full of oodles and oodles of hepatocytes. So on that little tiny, a liver biopsy sample is like very thin and stringy, about 2 centimeters long. And this is what you would see under the slide. So those are all the individual liver cells with all their little nuclei. And so then you can see on a fatty liver, you still see all those nice healthy liver cells, but you got the globules of fat interspersed. It can enlarge the liver, like I said. It can even change its color a little bit. And then a cirrhotic liver, you can see you have areas of healthy liver tissue. They call it regenerative tissue. And this is all scarring. So you can't see those hepatocytes any longer with liver cirrhosis. Next slide. And like I said, F0 to F4 is how it's labeled by a pathologist. So F0 would be no scarring, and then F4 would be liver cirrhosis. So treatment for steatotic liver disease, the only treatment we have right now, besides all what Dr. Swain talked, that's coming, and that Ozempic that's been around for a little bit now. We have to prevent injury to your liver. So how do we do that is we have to treat the underlying cause. So patients with obesity, gradual and sustained weight loss, 5 to 10% is kind of the goal of your weight. Good blood sugar control, good all your other medical conditions, making sure they're medically managed, but hypertension, a good diet. I'll talk a bit more about diet. And then lastly, I like to talk about we have to take vitamins and supplements wisely. I think a lot of people think if they go to a herbal store or natural store that there's something there that will help their liver. There is no known herbal medication that helps the liver. And so if there was, we'd be asking you to take it. Okay? All right. Next slide. So the treatment then is losing weight. We know there's many studies about the weight loss in this disease, and there are trials that indicate even 5% of your baseline body weight can reduce liver fat. 7% you can see reversal of inflammation and some scarring. Exercise doesn't have to be fancy. You don't have to go join a gym. It's just as long as you're getting your heart rate up, you're a little short of breath, but can still hold a conversation. That's what you, 5 days a week, 15 to 20 minute sessions. If you can only do 10 in the morning and 10, as long as you're doing it, you're doing yourself a good service. It helps move the fat out of the liver. And then healthy eating. So, you know, we never at our clinic tell somebody to have a set diet, because what works for somebody won't work for the other person, right? So really it's just eating more fruits and vegetables, avoiding those sugars and refined carbs, those high fructose drinks, less eating out, because we can control what's in our food better, and staying away from highly processed food. Next slide. So the healthy eating plate. So half of your plate should be the fruits and vegetables. You should be eating with your carbs, those complex carbs like barleys and whole grains, and then healthy proteins. When drinks we should be just sticking with water. We should avoid all those sugar drinks. Proteins with your meal, having fruits and vegetables with each meal. So just one change at a time, and they can all make a big difference. Next slide. So, you know, when something, the only treatment right now is lifestyle modification, it's certainly very overwhelming to us that, you know, oh, I have to lose weight. And it's not like most people haven't tried to lose weight before. And this is certainly a disease that waxes and wanes in our life. But just keep in mind, you can't be hard on yourself. You have to just pick one thing at a time. And so SMART goals are always very helpful to help set very specific, measurable, and achievable goals. And next slide. I'm almost done. My summary is, there's no treatment right now in Canada, right? There's no treatment. I have seen, since Ozempic we've seen a lot of our diabetic patients be on Ozempic, and I've seen some wonderful changes with the amount of fat in their liver, with the stiffness going down. I mean, it is, next person feels frustrated that sometimes they didn't lose weight, but even without the weight loss, it's still helping. So there's no signs and symptoms of this disease process. And I think when something doesn't cause us signs and symptoms, that it's easy to put it on the back burner and say, yeah, some nurse down, you know, a couple years ago, she told me I have fat in my liver and I should lose some weight, or I should do A, B, and C. But this is a disease that can sneak up on us. So we really do need to pay attention. And because this is a reversible disease with lifestyle modification, we can help make a change to it. Exercise, we've already talked, and treating the underlying cause. Next. I talked about that already. So, you know, and dietary support is really an integral part of the management of MASLD, right? So these are some very good websites and information, and some, like Alberta Healthy Living, which is by Alberta Health Services, has free programs for patients. They've got classes on non-alcoholic fatty liver disease. I work at the South Health Campus, which is the newest hospital in town. We have a cooking kitchen there. They have cooking classes. They have lots of things that patients can sign up for. I mean, and of course, Mike and the Fatty Liver Alliance, there's so much good information on there. I guess I'll back up and talk about a pathway in Calgary. So, you know, family doctors, let's face it, they're the first one that's going to see you and someone with fatty liver disease in their office. And so we really, and there's not enough hepatologists. I mean, we've got a lot of big population in Alberta, and we just don't have enough. So hepatologists, we can't see every patient who has this disease. So it's given, we have a pathway that was developed with hepatology as well as the PCN network, where we tell them, hey, these are the people you need to assess to have fatty liver disease. This is the next step. This is the lab work that you should do. Hey, let's do a FIB-4 score. That's a very simple tool that a family doctor can do in their office. That's actually now just a tick box on a lab rec, and it will start the process. It tells hey, once you get that FIB-4 result, hey, what should I do with that patient? Hey, that's low risk. I can keep that patient. I'll counsel them on diet and exercise. If it shows a little bit more, then we do more testing. And then it tells when to refer to specialty care. So it's a very, very wonderful tool. Yeah. I think that's it, though. Anything? Okay? All right.